morning all. Today we have a lecture. It's different from regional anesthesia topics. Also, it is not purely pain management. It is in between. It is in between regional and pain management with the neuromodulation. So here we want to start about the ultrasound guidance in neuromodulation and hydrodissection, how to use ultrasound techniques calls for. Okay, so by introduction, peripheral nerve entrapment are common but often under-recognized sources of pain. Entrapment neuropathy is defined as a pressure-induced segmental injury to a peripheral nerve due to anatomical structure or pathological process. The defining criteria of entrapment, according to Kashuk, include altered transmission because of the mechanical rotation from management of anatomical nerve. Many nerves entrapped occur at the area where the nerve travels through channel, tunnel, canal, but they also occur because of the trauma and potential scar strangulation of the nerve. The nerve has its own blood supply, vasa nervorum, as well as accompanying vascular structures. The compression of the nerve, whether intrinsic or extrinsic, can cause damage to the neurovascular structure, leading to ischemia of the nerve. So nerve entrapment can result in clinical symptoms that range from mild discomfort to numbness, paralysis, or severe pain. So the nerve entrapment may be present in varying degrees, leading to variety of clinical presentation. Nerve can be entrapped by several mechanisms, including mechanical, which may involve compression, constriction, overstretching, or edema. Entrapment may occur in tunnels, such as a carpal tunnel syndrome, between muscles, such as an axillary nerve between teres major and teres minor, and around the vessels, such as an occipital nerve for occipital neuralgia, for example, or between the bones, such as Morton's neuroma, across the joints, such as in superficial coronal nerve, and through the fascial penetration sites, such as anterior cutaneous nerve entrapment syndrome, or external compression, such as common coronal entrapment by the cast. So this is one example about the you can see here the axillary nerve and the axillary artery is entrapped here in between teres major and teres minor muscles as well because of the pain. And this is another example about the common coronal nerve entrapment by the cast for the patient had a cast or plaster of Paris. And here this is the common coronal nerve here is so superficially. So the compression by the cast for 1 month, for example, some patients stay for 1 month, 2 months by the cast, and here the compression leads to damage or entrapment of common coronal nerve, and that's, you see the red color or mark. This is the site of the pain, so the patient developed lateral aspect of the knee pain and numbness or weakness in the dorsiflexion. So we have two major mechanisms of the nerve damage. The trauma, first is the trauma, direct trauma to the nerve, what's called edema, which can travel proximal to distal of the injury. When this swelling reaches to the fascial penetration point, this can cause as a self-strangulation of the nerve and decrease nerve growth factor, NGF flow. Second thing, the shearing at the penetration point can also cause entrapment. And those seen during the distension of the abdomen during pregnancy, for example, causing anterior cutaneous nerve entrapment syndrome. Post-abortive entrapment syndrome, that's have a multiple mechanism by which surgery can cause post-abortive nerve entrapment. The pain can occur immediately after surgery because of the nerve damage from the retractor scalpel edema, or it may start weeks or even years after the surgery because of the scar that gradually tightens around the nerve. So the topics lecture today about the hydrodissection. What is the hydrodissection? And this is the introduction of the nerve and the mechanism of the nerve injury and trauma. And now we start to identify the hydrodissection which is also known as a preneural deep injection. This is a technique of injecting volume into a skull or fascia to release entrapped nerves. So this is the main topic, or the main project for the nerve release, to use the hydrodissection technique by ultrasound for nerve releasing. So the nerves are supposed to move smoothly over the fascia, but entrapment of these nerves is similar to adhesions in the epidural space, tethering the cutaneous and deep nerves and causing pain and autonomic dysfunction. The technique of hydrodissection requires both the skill of the identification of the nerves and the ultrasound, as well as the safe and accurate manipulation by ultrasound by the needle. So the goal to place the needle tip on the east side of the nerve preneural, but not inside the nerve intraneural. So this is the same mechanism, or the same tips of using the hydrodissection for nerve block, to put the local anesthesia surround the nerve, but this is for the normal nerve, the regional anesthesia. Here we are talking about the injured nerve, different anatomy, different pathology. So here, this is I think I will skip this, because here the lecture today about the using of the hydrodissection, and here more deep details about the enhancing neural regeneration by the electrical nerve stimulation, because now the upgrading of the clinical treatment of injured peripheral nerve is using of electrical stimulation to the injured nerve, and previously was just the surgical. So I will skip this and maybe back if there are any question about it, because I want to go through the hydrodissection of the neuroma as the title of the lecture. And also here is the pulse radiofrequency neuromodulation of the peripheral nerve injury, and the combination of the pulse radiofrequency, because you know that traumatized nerve have, the patient have complaining of the pain, allodynia, cramps, many types of the pain, chronic pain. So by here we need general neuromodulation, we need electrical stimulation plus pulse radiofrequency, that's for to modulate physiological changes of the nerve, and hydrodissection for the decompression or the mechanical decompression of the scarring of the adhesions. I will open the videos before go these details, because these details is very deep. And then back to the lecture. So I'm going to just go to. So here is the first example of hydrodissection. Here. Here, this is the ulnar nerve trauma. You can see the ulnar nerve here is abnormal ulnar nerve. You see there is no hyperechoic round shape with fascicles. It is a lot of scar and trauma. Now I do hydrodissection to release the nerve from the thick. See, this is the ulnar nerve now after hydrodissection. So it's different. Firstly, we saw a big traumatized nerve with non-well defined. So here, this is my topics today about the induction sign. This patient had median nerve injury after surgery for nerve acceleration failed after 1 year. The patient developed induction hand of the induction, unable to grip the hand because with the loss or deficit sensation of the dermatomes of the median nerve, failed physiotherapy, failed surgical interference, and he came to me tracing the medial nerve and the medial aspect of the arm. I found big fibrous and thickening around the nerve within neuroma. I had to dissect neuroma in the video now. and immediate electrical stimulation to neuromuscular junction, and immediately after 10 minutes he regained the grip. So this is the scar of the surgery. سوى لك استكشاف عصب؟
ايه.
ولا ما رجعت له؟ ما رجعت. هو جالس يسوي استكشاف عصب؟
عملية سوى.
هو مع العصب، هذا جد.
لا حرام.
صار لك سنة يعني، والله. وما رجعت عندك.
لا.
إحساس عندك هنا؟ إحساس؟
مطول.
بس هاي جالس تسويها. This ulnar nerve is alright, but medial nerve very weak. حس؟
ايه.
يعني هنا
ايه.
يوصل أصابع تسويها؟
لا هسه لاني
لأن الحس بينا. ulnar nerve intact, medial nerve.
ايه.
هذا.
ايه.
زين. بس خلها.
شلون عم باخذ من فوق؟
سد ايدك هيك. لا جبهة كده. هاي شكل. What you over here, can see. Some ulnar nerve involved in the motor because of disuse. Sit. Not قوي. هذا أبد ما يكون عندك. حتى لو ترجع هنا توجعك. افتح. سد قوي. افتح قوي. سد. هذا حرك اليوم. هذا الإبهام. حركة للداخل. هذا حده ما يقدر يكون هنا. هذا ما يتحرك، هذا ما يتحرك. لأني يمسك، سد بس للمثلين. لأني ما يمسك. هذا. سمعت. So here, this is the axillary artery. This is the medial nerve. Now I will scan down here to see there. This is the medial nerve now. The medial. See the neuroma. Big neuroma. So this one. This is the medial nerve, and this is the neuroma. So here the side and fibrous tissue. Now the continuity is normal. So continue. Here this is the normal, but here big neuroma. And here normal. So first I use normal saline for hydrodissection, separate the nerve. Now I am through the nerve or is the hydrodissection technique. It's painful, but I need to await patience. See the twitching there? Now I start electrical stimulation. This is the hydrodissection now here. From this level. Direct electrical stimulation. This is the nerve now. See, this is the thickening, it's separated from the nerve, the thick fibrous tissue. Here is the medial nerve now. This is the hydrocone, the neuroma. And now I will stimulate. See the camera. After. See the difference? This is from the start. We are at the middle of the session. Sit. Sit قوي. اصبعك هذا اللي كان يتحرك حركية هذا بالداخل. الإبهام. لا داخل الداخل. يعني كان يتحرك. The rest of the lecture will explain what happened during this. افتح. Sit. In 5 minutes. Again, the function of the medial nerve here. Okay? How does the section start? How does the how the big one? The inside, this is in your own. So with all this thick tissue, the plastic tissue from the trauma or from the nerve, ischemia from the nerve. How do you know this? And this is the neuroma. لا سيسدي لك. قوي. افتح. سد. افتح. سد. سد. The induction sign. شق. بعد. افتح. افتح. سد. افتح. سد. بعدنا شوية. يلا. This is the end of the procedure. بعد. افتح. سد. افتح. أعطانا الكبرى. The induction sign. شلون كان قولي لك؟
متسدد.
So this is the last video here and then back to the lecture to understand the patient have trauma to the forearm. Now complaining of the pain here in the medial aspect of the forearm. صار تاخذ هذيك work so now complaining of this patient have shell injury, is military, have shell injury in the medial aspect of the arm and the forearm. He developed severe neuralgia in the medial aspect of the forearm. He went to different doctors, orthopedicians, and neurologists. All of them gave him just pregabalin or gabapentin or just neuropathic agent, and he already did a surgery for shell removal and tendon reconstructions. So after the surgeries, I think because the medial cutaneous nerve of the forearm or arm so superficially, so it is cut by the knife of the surgeon and then healed with the adhesion within the skin, and that developed neuralgia, allodynia, just with the light touch here to the medial aspect, severe agonizing pain. So we'll show you pain here in the medial aspect of the forearm. صار تاخذ هذيك work so by ultrasound we can see just tracing the nerves. So here we have brachial artery, medial nerve. See this is here, medial cutaneous of the forearm, and here this is the ulnar nerve. Now scan down. So then I see the neuroma here very clear. This is the neuroma of the medial cutaneous of the forearm. And here the medial nerve, the ulnar nerve intact, neuroma of the medial cutaneous. This is the nerve, and this is the neuroma of the medial nerve of the brachial artery. So I do the dissection of this neuroma. So it's a bit like a vascular structure, but this is a neuroma or tumor. So this side of incision, you can see. Okay. So this, I think this is from the surgeon, not from the shell itself, because now you see the needle now. خلصنا يا بطل. Now I will have to dissect. Yes. Now the neuroma. See the nerve now. See the neuroma. Very clear, and the nerve. خلصنا. It's painful. The neuroma into that section is so painful. But you know we have a pain management, general anesthesia, just mild sedation of the patient. So here the nerve. See now the nerve is different. This is the arising neuroma. So how do you see how many layers surround it? This is the nerve and this is the neuroma. See after having the dissection, see how many layers, double layers surrounded the nerve. So this is the thickening from the fibrous tissue, scarring, granulation, neuroma itself. So after having dissection, the nerves appear by 50-60% from echogenicity of the nerve, and immediately the pain or the neuralgia is subsided. So this is the one. You see how to dissect it. Now this is the nerve. Smack. Feet. Yeah. خلصنا تبطل down. This is like a microsurgery. Even in surgery, nobody can dissect the nerve like this. Less than 1 millimeter. This is the medial cutaneous of the forearm. See the nerve now appear here, the ulnar, so here the forearm, and the medial nerve normal. Now see, decomprise the neuroma. See the fibrous tissue here, and now thickening. I will do radiofrequency here. Now the nerve very clear. To have a lot of adhesions around it. And also now the last one.
One question is regarding after dissection. It will come like compartment because high pressure around the neck.
No, I just use 2 to 5 ml maximum.
Maximum.
It's like when you give local anesthesia to any nerve, 2 to 5 ml, not 20 or 30 ml. Of course, it will be little more conversion and ischemia. So I use for the fascial layers or the nerve under penetrating points of the fascia. Just release the fascia and then go to the pinurium. But for the plexus, for example, no, I reach to the 10 ml, 15 ml, like a brachial plexus. That depends to, it's the same rules of the nerve block, peripheral nerve block. For the plexus, huge volume. For the small peripheral nerve, small volume. It's the same tool. So what I mentioned from the start, it is a combination of regional anesthesia and pain management to reach to the level of the hydrodissection or neuromodulation. You should know this nerve, how many ml is enough for it. This nerve or this plexus, how many ml. So this is the last one, and then back to, I think, I'm sorry, because if you allow me, so Mario, allow me to take 10 minutes more for lecture because it is a new things for the pain or upgrading of the pain. So when I finish the videos, because I want the idea to be mature now, and then back to the lecture about the electrical stimulation and the radio frequency and how the difference in between this. This is also be the nerve injury.
Nerve injury, GNCS, neurokinesis, neurokinesis. I will trace the median nerve from distal part of the arm. خضر هناك اثنين؟ اوكي.
The median nerve here, how is it tied to the tissue here? It's one piece with the muscle. This is the median nerve. I just want to separate it from the traumatized muscle. And this is the artery. This is the artery. The only things here is the painful procedure. We need heavy sedation and depend to the patient threshold. But the pain just through the hydrodissection, when you separate the thickening of the nerve, that's it, not the manipulation of the needle.
طبيعي؟ صوم كله جيد بس احساس شلون طبيعي؟
Thyroid, 10 minutes.
كان خدر كلش قوي؟ وهسه بس اصبح ايدك كانت تطبق هيك؟ تبقى لا يا
And see from the start. This is the form from the start.
كل قوة اصبح شدك هسه كان خدر كلش قوي؟
And the end.
وهسه بس اصبعك شديت هسه
ماجيك.
ايدك كانت تطبق هيك تبقى لا حتى الابهام وياك تطبق الابهام.
Okay. Now I will back to lecture to explain what happened.
Surgeons are going to page you. Surgeons are going to page you. You're taking part of the work.
Yeah, we can check also. So again, so firstly here we identify the nerve entrapment and the cause of the nerve injury, different cause, mechanical cause, surgical cause, trauma, anatomical cause, and then we talk about the postoperative nerve entrapment and then hydrodissection. You see, and now we reach to the what we do during the hydrodissection for the functional recovery. We are talking now about the nerve electrical stimulation and pulse radiofrequency, what I did in all these videos to get the functional recovery. Some patients in immediate functional recovery, and some of them need 3 weeks to 2 months for the reinnervation of the atrophied muscles and regain them. So here we'll talk about the enhancing neural regeneration by electrical nerve stimulation. Currently, clinical treatment of injured peripheral nerve is exclusively surgical, either releasing of the source of the nerve compression or reattaching the transected nerve directly or with the grafting materials. So, surgery encourages nerve regrowth by connecting nerve stumps by functional recovery remains inadequate. This is the aim of the surgery for peripheral nerve, for nerve regrowth, for reanastomosis or reconstruction. Why they do the surgery for sciatic nerve injury, for example. This is the aim of the surgery. Now we will talk what is the aim of electrical stimulation and how it's replaced most of this indication of the surgery. So surgery encourages the nerve regrowth by reconnecting, by connecting nerve stumps, but functional recovery remains inadequate. So nerves in a human patient regenerate slowly, 1 millimeter per day. So requiring long period of time to reconnect with the denervated target muscle or sensory end organs. The more proximal of injury, the less likely the patient will fully recover. So the patient with a brachial plexus injury needs long time to recover, while the medial nerve injury and cubital fossa needs less time, and that's for all the nerves. So the window of opportunity for the nerve regeneration is short, with the regenerative capacity of the injured neurons and the regenerative support of the distal nerve stump declining with the time and distance. These factors, together with the misdirection of regeneration nerve, account for the frequent poor recovery. That's for the peripheral nerve injury. By the way, this is important in our work also in peripheral nerve anesthesia, or regional anesthesia, because if you do some fault or mistake to do intraneural injection and nerve damage after surgery, and then the surgeon, the patient will complaining because of the motor deficit, here you can use your techniques to manage your complication. It's written in the book, you have nerve complication after, for example, interscalene block, or after brachial plexus block axillary approach. Now, with this technique, you can manage your complication also, not just give the anesthesia. Give anesthesia and manage the complication if occur. So here, the ability of the electrical stimulation of the peripheral nerve proximal to the site of injury to accelerate nerve regeneration and target reinnervation was first established in 2000 for motor neurons and later for sensory neurons. Continuous electrical stimulation for a period of 1 hour at 20 Hz, which has been adopted from animal studies, was also shown to be effective in accelerating target reinnervation in a human. So specifically, human nerve regeneration was accelerated following complete transected and immediate repair of the digital nerve, as well as following the conversion of the carpal and cubital tunnels. Electrical stimulation requires that action potential are elicited in the antidromic direction toward the neural cell body, and this is a return upregulate in neural. This is the mechanism. The electrical stimulation elicited in antidromic direction toward the cell body, and then upregulate the neuronal cyclic adenosine monophosphate CAMB, which leads to upregulation of the brain-derived neurotrophic factor BDNF, and ultimately facilitate the enhanced of regeneration effect. So this is the mechanism of the electrical stimulation and what occurs. So injured axons regrow from the proximal stump and transverse the injury site to reach to the distal stump, and then later the denervated target organ. Electrical stimulation does not change, this is the important, does not change the rate of regeneration, but instead it accelerates nerve outgrowth across the injury site, which for the regrowing axons typically serves as the largest barrier to transverse the proximal stump and transverse the injury site to reach the distal stump and then later denervated target organ. So here, this is the aim of electrical stimulation to accelerate. It is never change the rate of the regeneration because that's depend to the Schwann cell and mitochondria inside the nerve. So upregulation of the intramuscular mRNA levels of GDNF may accelerate the functional connection with denervated neuromuscular junction by allowing axon to branch extensively, a phenomenon that was observed in the mice that genetically overexpressed intramuscular GDNF. So another explanation may be increased intramuscular mRNA levels of brain-derived neurotrophic factor and GDNF glial-derived neurotrophic factor lead to increased synthesis of the trophic factors. The factors, this is the mechanism. Diffuse proximal and act of the advancing growth hormone to enhance the nerve outgrowth. So both electrical stimulation and electrical muscle stimulation promote nerve regeneration and accelerated muscle reinnervation. That's why in the physiotherapy they use the TENS or galvanic or electrical stimulation through the muscles to enhance the reinnervation of the denervated muscles. So they have this the plan through the muscular stimulation. Now we have through the nerve stimulation. The physiotherapist cannot reach to the nerve, such in the pain physician or the regional anesthetist. We can reach to the nerve by ultrasound. We can identify the nerve. So we are skilled by this. So this is our work to how to stimulate the nerve. The physiotherapist stimulate the muscles direct for this mechanism to outgrow the promote regeneration and acceleration muscle reinnervation. So the effect mediated via the neurotrophic factor upregulation in the neuron and the muscle respectively, whether the two therapies produce a synergistic effect is an important question that remains to be addressed. So here we have two ideas through the muscle stimulation to reinnervate the denervated muscle, or direct stimulation for the nerve to supporting or acceleration of the reinnervation of the muscles through the passing the electrical signals from the proximal stump to the distal stump. So, what is the effect of the radiofrequency? All of you here use the radiofrequency for the pain, for the chronic pain, not for the functional recovery of the nerve. Now, here we showed how we use the radiofrequency modulation. Even in the patient you saw in the videos have pain, allodynia, neuralgia, the pulse radiofrequency here will play a role for the pain, for chronic pain management. But here also we have, by the way they found, the scientists found the pulse radiofrequency enhance the nerve regeneration. How? We will see in this two slides. Pulse radiofrequency is a pain management technique that involves placing the needle electrode near nerves and generating electrical current pulse in order to modulate the transduction of somatosensory information through the nerves. So the technique evolved from a similar radiofrequency produced in which constant current distributed to the nerve. So in the case of continuous radiofrequency, however, the destructive lesion can cause further complication and unwanted side effect according to the approach. This is the comparison between the pulse radiofrequency and conventional radiofrequency or thermal radiofrequency. But what we need here, the novel pulse radiofrequency technique have been used successfully to treat the multiple chronic pain conditions including joints pain, myofascial pain, neuralgia. Although complication and side effects are generally less common compared to radiofrequency thermal regulation. So the safety margin of the pulse radiofrequency is high, and the pulse radiofrequency applied by radiofrequency generator producing alternating output voltage of 45 volt to 5 kHz. So the target in neural tissue is stimulated by the electrode positioning at the target site and ultrasound or other guidance. The studies show that this is the importance of radiofrequency, the ultrastructural changes observed in the sciatic nerve after pulse radiofrequency induce extensive mitochondrial swelling and hyperplasia, while no mitochondrial swelling and hyperplasia are observed in the control sciatic nerve. So this is the this is figure 1, the ultrastructural damage of the sciatic nerve. This is the sciatic nerve damage. So including demyelination, Wallerian degeneration, and axonal degeneration. Following the chronic construction injury, So found here, sorry. So the scientists they took a rod and do ligation of the sciatic nerve bilaterally, and after 2 hours the ischemia developed and the foot-drop bilateral developed, and then do radiofrequency for the right lower limb and leave the left lower limb for the normal regeneration. They found the radiofrequency of the right limb after 3 weeks, the dorsiflexion regained and the functional recovery of the, while the normal or actual regeneration remained 6 months to regenerate. Then they took another case, they took harvesting the tissue, and for histopathology they found this in the histopathology or in the microscopically the changes of the pulsar frequency on the nerve. So here you can see large clusters of collagen observed around the severely disrupted myelin sheath, and the number of axons and mitochondria were greatly reduced. So this is for the damaged sciatic nerve. You can see this is the problem or the nerve injury, the large clusters of collagen fibers and disrupted myelin sheath, and the numbers of the axons and mitochondria were greatly reduced. This is the after pulse radiofrequency. See the difference here. So the majority of myelinated and immyelinated fibers had normal microstructure, including intact myelin sheath, mitochondrial hyperplasia, and swelling were seen in some axons. So here the Schwann cells also uniform, nerve fibers. They saw some myelin sheaths were irregular with loss of laminar-like structure. So the damage after pulse radiofrequency reduced, the mitochondria increase in the size, hyperplasia, and that's mean the power or energy to the nerve for Schwann cells to regenerate is enhanced here, and also the myelination here is arranged more than the sample without radiofrequency. So the mechanism of the pulse radiofrequency action are still unclear, but for the functional nerve, but it is known that change of CFOS and ATF3 expression and level of the local inflammatory factors are involved after pulse radiofrequency treatment. We propose that pulse radiofrequency to the sciatic nerve relief by altering the peripheral nerve both functional and structurally. So here also the pulse radiofrequency playing a role for the functionally and structurally nerve regeneration. So the conclusion here, the introduction of ultrasound to interventional pain medicine has expanded and modalities available to the clinician and has increased the understanding of the pathology involved in the nerve pain. So interventional physicians skilled in ultrasonography are an important member of the pain care team capable to special skills and cell method and the target nerve injury and fragment neuropathies. And the efficacy of the pre-electrical stimulation of a proximal stump of an injured nerve is promoting nerve regeneration. So these are the studies and the groups who do the study of them. Thank you. We have the time is, we have 5 minutes more, 3 minutes more. And before the questions, we start. This is the last case of different case. It is the story of this patient. So far, was a nerve injury because of the fracture humerus. This is fracture humerus. This is a very common case to our. This fracture humerus, the patient have cardiac disease, ejection fraction 30, and balance surgery from another city, not from Baghdad, from the south. Nobody can give him regional anesthesia afraid from him. The patient has multiple comorbidities, and then the surgeon, orthopedician surgeon, put the patient in a cast or POP for 2 months, and here the complication started. Nobody knows the wrist drop is from the injury itself or from the cast, ischemia, or after the surgery, because the patient, the surgeon, when he did the plating or fixation of the humerus, also didn't examine the wrist extension well. So after surgery, the patient came with wrist drop. So we have 4 differential diagnoses. The injuries from the site or from the time of injury, maybe from the cast and ischemia, maybe from the surgery, maybe from the regional anesthesia itself. Right. Okay? So here you should differentiate. Of course, we send the patient for EMG and nerve conduction study, and that illustrated this is the axonal axonotemesis to neurotemesis of the radial nerve. So it is not from regional, it's not from surgery immediately, this is from the cast or from the time of the injury. So the patient needs a solution, wrist drop, 6 months physiotherapy after the surgery. So the patient here came to me after 9 months from the trauma, after 6 months from the surgery, with complete wrist drop, and also the weakness of the hand gripping because of the median nerve neuropathies, maybe due to disuse of the hand, develop this. So you'll see in this video, it's a 5 minutes, you see the procedures and what occurred after 3 weeks. And injured by fracture, EMG, proximal to spinal groove injury, axonotemesis severe, moderate to severe injury. ارفع راسك معك، بس الرسم، بس الرسم، ارفع بس الرسم. زين، سوي لي اوكي. سد ايدك على زيرو، ارفع الهام لفوق. سمعت ايدك ترفعها عبد، سد ايدك، فرها، سدها. Also, median nerve problem, mild median nerve injury also, the EMG. جاب تحت الولاء واحد جي من جوا بس احساس عندك بيها this is the site of the surgery and the site of the fracture humerus here. حاول اسوي ثلاثة محجي فحم ثلاثة نزل كان هاي ارفع نعم هاي السدة مالتك يمين. So here this is the somehow absent because of the radial nerve injury. So here this is the radial nerve after leaving the spinal groove. Now I will scan proximal to see. Here, this is the radial nerve, here the radial nerve, and here, see the fibrous tissue around it. The fascicles hypertrophied. See, this is unusual. Anyone do radial nerve in spinal groove? Now the radial nerve here, this is the hyperechoic structure that's been hypertrophied, or the fascicles are here with thickening or double, like a size, the diameter like the size of the nerve. This is from the scarring of the trauma itself, or also from the surgery, or from the delayed surgery. So here it is double entrapment of the nerve. And here, you can see the screws. The screws here, this is the fixation. So the nerve is intact, the continuity is intact. There's no nerve proximal. And here, the radial nerve here. So it has to the spinal groove disrupted. So here, this is the proximal side of the radial nerve. I will start stimulation from here. As seen in the EMG, can see here, this is the chronic lesion of the right radial nerve above the elbow, above the spinal groove, of group of moderate to severe degree, axonokinesis with distal to proximal gradient, axon degeneration. Also here, the median nerve also have moderate severity of
شكة بسيطة عن مقطعها هسه.
Now see in the ultrasound, you can see the needle go to the, here, this is the radial nerve now. This is the radial nerve, this is the needle. See the needle? Okay. Now I will start the stimulation from here. This is the needle. Okay. Now start the stimulation. So 3 volts. See the triceps muscle? But see triceps muscle? No, extensor, just the triceps. But the extensor didn't work here. Because the stump of the nerve just reached here, the muscular branch of triceps. And here there is no any regeneration, so zero conductivity. So 3 volts, no, I will try 5 hertz, 0. To do sensory stimulation. And sensory stimulation, this is a functional for to localize the sensory nerve, change the numbness during the pain procedures. But here I modified it to give a 3 volt, 200 hertz. 200 hertz, it's a very big number for the nerve conductivity. So here I give 3 volt and 200 hertz rate. So that the patient feel by the electricity inside. So I am sure the nerve is connected. See this is the sensory.
You said here no connection here.
Because the sensory, when you exceed the 0.5 volt, it is switched to the motor.
And here to see the see the sensors.
ما هي مقابلك، قلبك ما يمشي، لا تعرف. See here just the triceps and collateral muscles working, but no extensor. Till now, 0. So this is severe injury. This is not that like a median nerve have rupture. This is after 3 weeks, 2 weeks to 3 weeks. See the extension now? The patient sent a video from home by Viber. I am good now, my thumb up, I can write, my wrist is okay. See the median nerve also, I did the median nerve stimulation, and so I'm good now, right? And this is the wrist. More sessions, second session. That's it. Thank you. Any question?
Yes.
I know it's a question. I am ready for that. Okay. Yes.
Regarding the hydrodissection, how you can define the first layer to start to avoid nerve injury because it's already injured. Second one, if we want to explain the patient can medico-legal bond. All the mechanism is unclear regarding the RFA, the mechanism how to work unclear. So many patients, nagging and irritating, and they ask how it works.
No.
If we answer unclear, is medico-legally covered?
Yeah. After all the protocols to save the patient nerves from the other doctors or other specialties, plastic surgeon, orthopedician, physiotherapist, rheumatologist, whatever. The patient came to me, so I am a referral or tertiary center for the injured nerve could not be managed by other specialty. So I am the last choice for the patient. I am not the first step. I didn't receive any patient with nerve injury directly. Go to neurologist, go to neurosurgeon, go to orthopedician, do the ABC. After failure trials, back to me, I will be ready for you. So this is the trial, firstly. Secondly, from the medical legally, it is not overkill procedures. Of course, if you do nerve block, someone can ask you why do you never give GA, it's overkill, you give the nerve, maybe you inject the nerve and paralysis. It's a procedure like a pain management procedure when you do hydrodissection for the fascia, for the musculoskeletal injection, whatever. When you see the pathology, you want to hydrodissect. Okay, you here see not well-defined epinuria, but here you should identify the epimysial layer from epinural layer. This is the tip. The epimysial layer, which is the muscular layer, adheres to the nerve in the normally, or the fascial penetrating point with the nerve penetrate the fascia and go to the target muscles or skin, whatever. So here, do not identify the epinural because it's disrupted. Go to the surround structures, to the muscles or fascia, and then go through the fascia. How to dissect the fascia? The nerve will be more clear, and then be more clear. Then go to layer by layer. So this is the answer from. By the bus radiofrequency, it is not irritant because here you use 45 voltage and bus manner by 40 centigrade temperature, so it's never irritant. And I saw by my eyes, I put the nerve, the radio frequency, and see the nerve start to be hypertrophied or increasing in the size after 2 or 3 minutes from radio frequency. So hyperplasia of mitochondria and intrinsic vessels is very obviously seen by pulse frequency. Okay. Another question?
You have a nerve that is damaged.
Yeah.
You have a scar tissue around.
Yeah.
I want to know if there's any liquid among the scar tissue. Have you seen if there's any liquid?
Yeah, I have one case, but I think it is in my YouTube or laptop. Patient with a sciatic nerve injury, 1 month in conservative treatment, he developed just a plantar flexion weakness. Dorsiflexion is okay. So it's bad surgery. The orthopedician decided no surgery. Then the orthopedician sent the patient to me for tracing. When I traced the nerve, I found there is a hematoma inside the epinural of the tibial nerve. Okay? So I entered the Tohi needle. To aspirate this, I inject 0.1 heparin to liquefy. This is the hematoma, because it's thick hematoma inside the epinural. And then aspirate the hematoma and decompression of the hematoma. Second day, the patient regained the plantar flexion. I recorded this case.
But in this case, you say you refer to there was a hematoma. I want to know if it's between.
No fluid. Dehydrated, very thick, dehydrated.
Wow.
No fluid. The fluid is from me when I inject. Otherwise, there is no fluid. It is very dehydrated, tight, thickening, scarring, granulation, tissue surround the nerve. So this is the cause of the severe pain, irritation, or allodynia, or trigger point pain, or motor sensor deficit. Yeah.
You use radio frequency for 1 hour?
No, electrical stimulation.
Electrical
Yeah,
stimulation.
radio frequency 2 to 3 minutes maximum.
2 or 3 minutes.
Maximum.
And the relation between the tip of the needle and of the nerve, you change this duration in this relation in the 2 or 3 minutes, or in the same?
This is a good question. When you are familiar with the peripheral nerve damage procedures, you will find, for example, I have patients have, for example, medial nerve injury, but the weakness not on the index, the weakness in the third finger. So I change the electrical stimulation, the direction of the tip, up, down, lateral, to see here. Each nerve have different site or fascicles or fibers. These fibers supply the index. This fiber supply the middle finger. So this is the tricks of the nerve. So you can do selectively fascicle or fiber stimulation, not all the nerve stimulation. This is very important. You can see it's clinical if you have electrical stimulation. Ultrasound. Go to the medial nerve posteriorly. Go to the medial nerve anteriorly. Go to the lateral and through the low current. See which finger will start, thumb or index or middle or ring.
And you have any experience with PRP?
No, I don't use it.
Okay.
That is important to know. Axonal embryology.
Yeah.
With the distribution of the fibers into the nerves is good for try to select stimulation and neuromodulation. 1 hour, 20 hertz.
Yeah.
It's important. I usually use in my clinic hydrodissection and radiofrequency into the fascia with hypertonic saline solution. The result is good. The reason is this: the doctor don't use radiofrequency into the fascia because they always use near to the nerves. I think it's a good option for the patient with the chronic pain.
It is added option. The radio frequency here, you can do hydrodissection or releasing of the nerve, and I think it's give you at least 50% from next step of nerve regeneration, because here the entrapment release, the nerve now extrinsic and intrinsic vessels will regain normally, so oxygen will come, nutrient will come, mitochondria will work normally, and then the regeneration, the Schwann cells will start regeneration. But with entrapment or ischemic nerves, the blood supply is very less, so low oxygen, low nutrient, Schwann cell is very slow in the working, and then gradually after 6 months, 9 months, 1 year, the regeneration is stopped. The signal from the brain for regeneration growth factor stopped because it's hopeless. That's what I control the reason. Why we previously advised, till now, advise the patient to do physiotherapy, just to functional, to re-innovate that. So this is now, it's more invasive physiotherapy and functional and deconversion and management procedures for the nerve injuries, not just physiotherapy.
Use any additional drugs during your procedure, like steroids?
With the very big neuroma, I'll use dexamethasone, just 2 to 4 milligrams, that's it. Mixed with the normal saline, and this is like anti-inflammatory effect, immediate anti-inflammatory effect during the hydrodissection, and also to reduce the nerve edema after hydrodissection.
How many sessions?
How permanent is this hydrodissection with saline? Will get absorbed. The skull will regrow and collapse. Do you get many people coming back?
Yeah. Here we have the scarring is formed by the inflammatory process. When you do the trauma, the inflammatory processes start. Then the patient put the POP, cast, whatever, more conversion, and then granulation tissue and sticky to the nerve. After you do conversion, there is never another trauma, or there is no continuous trauma, so inflammatory process or adhesions or scarring subsided. Okay, it's narrow tunnel, still narrow tunnel because distorted anatomy, but not adhesions or fibrosis to them because you decompress already. So the problem of the adhesions or it's from the inflammatory process, it's occurred in primary cause. Regarding the neuroma, here the neuroma decreases in the size after radiofrequency and electrical stimulation. This is from functional electrical stimulation, or the proximal stem give a new connection to cross the neuroma and reach the distal stem. It's like alternative to surgery when they cut the neuroma and through radiosynthesis, the same aim. So this is a part of the nerve is not functioning. We should find a pathway, another pathway. The fascicles have 5% working, 95% not work because of the neuroma. This 5% hypertrophied to reach to 50%, for example. So this is a new connection, reach to the distal stem, and then to denervated muscles, and then reach to the distal. It's a kind of the workshop. I'm sorry.
Thank you.